Hi, it's Rafaela Catherine Crosby from Migraine Australia. There's a doctor that's actually inadvertently responsible for Migraine Australia existing, and that is Dr. Craig Costello. He's from Townsville, and he was the first doctor to put me on Aimovig. We had a chat to him about the difficulty of operating in a rural area and servicing clients that often have to travel hundreds of kilometres to come and see him. What's it like to be a neuro in a regional area? Well, it's busy.
Is that this is an incredibly common condition, and it's even when you go, so if you take all of migraine, it's really, really, really common. If you even just go to the subset of chronic daily headache of migraine origin, it's still a very common problem. And so, if you read the literature, depending on which bit you read, it's anywhere from 1 and 1.5, maybe up to 2% of the population. So if you look at Townsville, that's probably roughly 4,000 people, somewhere between 3,000 and 4,000 people that need access to good, ongoing, recurrent, potentially injectable treatment, such as Botox, or other. There's just not enough of us to deal with that many patients.
How many neuros are there in Townsville? There's you and Dr. Five.
But there's really only 2 of us who inject.
Yeah, that do Botox.
Yeah.
Yeah, all right. For the benefit for people watching this who aren't familiar with Botox, can you just give us a very quick, what is Botox treatment?
So, Botox is a neuromuscular blocker. So it actually blocks the nerve ending releasing the chemical messenger. From a migraine point of view, the hypothetical theory is it prevents peripheral to central feedback, which ingrains that cycle of pain. When you consider the group of patients that get benefit, a lot of them have some sort of daily headache, which doesn't particularly look like migraine, but we're confident is driven by the migraine process. But the muscular relaxation probably is a component of its benefit, as well as the other scenarios. But it is, it's a therapy that's available for people who have a diagnosis, that have tried and failed other agents. And it's provided typically 12 weekly. There are requirements for people to show a response in the early stages, and if you show that response and there's a very specific standard on that, then you can have ongoing injections on the PBS, which removes a significant cost impediment, because it's a large amount that we use overall in lots and lots of little places with small doses. But if it wasn't for it being on the PBS, it would probably be $800, $900 of toxin. Just to get access to it. But that's really what it is. It's got science behind it. There was 2 major randomized studies done 04, 05-ish. I can't remember the years now, but it was a long time ago now, called the Preempt studies, and that's the protocol that we follow, because they're the ones that show that they have benefit.
So how many Botox patients would you see?
I find that hard to estimate off the top, but I typically would say I inject somewhere between 20 and 25 patients a week.
Right. And they're from all over North Queensland, aren't they? They would travel. Some of them would travel to Townsville, Yeah,
some travel to Townsville and some travel to Cairns. So I go to Cairns every 3 months. And so I went to Cairns last week, and on a fairly condensed clinic, because of available flights and stuff, I think I injected 17 patients. Now, I would say 12 of them would have been migraine patients. A few of them would have been other indications for Botox. But by far and away, the most significant amount of patients that do Botox now is migraine patients.
So what happens in a situation where you've got a very limited number of neuros, you've got people travelling from all over the area, to get that treatment. Do you get to a point where you just have to say no to some people, or do you just try and see everybody and do your best?
I don't say no to people. I don't think it's my position to say no to people.
Mm-hmm.
I look at where it becomes hard for me, for example, more so is when my visiting cancer clinic, because it's becoming harder and harder and harder to fit all of the patients that need treatment into my cancer clinic on a recurrent basis. In Townsville, it's manageable. I've got flexibility, but what happens over time is the more patients that you get into your care that need recurrent treatment, means that as that works, more and more patients for all sorts of neurological conditions that I look after, wait times go out and it becomes harder to initially get in and see me. So that's the real difficulty. There are other barriers. I've got a lady today that I saw that really needs a trial of Botox, or she needs a trial of Botox or one of the alternative CGRPs that are not on the PBS at the moment. But she can't do the CGRPs because of cost, or the concern with cost beyond the initial couple of months. And she's from about 800 kilometres away. And trying to travel 800 kilometres potentially every 12 weeks, or 1,600 if you count it as a return trip, is not doable for her. And so there's a perfect example of somebody that just can't access viable treatment options.
And for whom the CGRPs would be life-changing if you can get them.
Well, if we could get them for her on the PBS and they work for her, yes, it would be her obvious therapy. You know, there are lots and lots of people out there that need access to recurrent treatments, particularly for migraine. And not that there's an actual way necessarily, to do it, but sorry, I shouldn't say there's not a way to necessarily do it. It's a different approach, but you can't help but look with some envy at, you know, the Heart of Australia bus and that sort of setup, which I think have been set up for different reasons per se, really to screen patients and stop them unnecessarily travelling back and forth for just consults and investigation.
You need a migraine bus.
But that's it's a model that just so works, because most of these places where people sit that need care, they're never going to have the population to have somebody sit there.
Yeah.
You know, and nobody's going, government, private or otherwise, is going to fund the facilities to set it up and have it sitting there when it's only used once every few weeks or whatever else like that. So you clearly need something that is mobile and moves around.
There are subsidies and supports that we've been told about for people to travel distances, but one of the things that has been reported to us is that they will only fund to go to the nearest neurologist in their state. And that's obviously a problem when you're talking about people with migraine, because there's some neurologists that just don't care. And of course, if you need Botox, then you have to go to a specialist neurologist. So something mobile that can go to people and particularly can do awareness and education, because the other thing we found with our rural patients is, you know, it may take them 20 years before they convince their GP that they need to be referred off to somebody in the city.
Well, the biggest difficulty with the commonness or the commonality of migraine is, and the commonality of headache in general, is it's under-recognised and under-diagnosed, significantly so. And so one thing is, once you get a diagnosis, getting access to good treatment. The other thing is getting it recognised. And I think, you know, I have a significant respect for my primary care colleagues in general practice land. It's a tough job, and the real tough job of it with migraine is, okay, if somebody comes in and says, oh, I get these visual speckles and I get a one-sided headache and I'm vomiting, okay, cool, it's migraine, you know, and there's no troubles with it. But migraine presents in so many varied and different ways. And I just know from my experience, it wasn't until I started doing neurology on a day-in, day-out basis, and you're sitting in clinics and you're listening to stories, that over time you calibrate and you get used to the atypical presentations of migraine, and you get much better at picking it and diagnosing it just because you're seeing it all the time. And that's one of the barriers that we have, is a lack of recognition of it. And then the thing is, when it doesn't scream migraine to a general practitioner, for example, knowing that it's hard for people to get in and get seen, it's harder to generate a referral, because they know that, you know, it's going to take ages to get to be seen, and then they may not even get seen, etc. So there's a lot of system-based issues, as well as education issues and recognition issues that really need to be overcome to provide better care for the migraine population.
Is there anything we can do as a migraine community that would help our brothers and sisters in the migraine fight in rural areas?
Set up a migraine bus?
We'll put it on the wish list.
Look, I think the only thing you can, not the only thing, I think one of the things you can do is encourage them to be persistent. And I think if someone's had headaches for a long period of time and they haven't got a clear diagnosis, everyone deserves at least one visit with a neurologist so that they can get clarity of their diagnosis. And so I would just encourage them to be persistent and say, look, I really want to go and see someone. And even if I am so remote that I can't viably go back and forth and see them all the time and get proper treatment, I just want to clarify my situation and where I'm at. So I'd encourage you to encourage them all to be persistent and push to be seen. Beyond that, it's always about just making the regular representations to appropriate bodies that we don't have enough specialists in regional areas.
Yeah.
And I've been trying to get that solved for years, and unfortunately it's not easy to. You can put all sorts of mechanisms in place. The difficulty is having people wanting to come here. And I don't get it. You know, I honestly don't get it. I come to Townsville and I think, why would you want to live anywhere else? But there's plenty of people that don't want to live here. And they don't want to live in other suitable regional areas, be it Cairns, be it Mackay, etc., where you can actually get the balance of work and life. So I just continue to make representations and continue to push. And if you come across a friendly neurologist somewhere, try and encourage them to even visit regional areas and provide services.
Righty. Thank you very much for your time.
No problem. Thank you.